Morning, everybody. Welcome to our webinar, A Peek Behind the Funding Curtain of Standing Devices. My name is Marianne Girardi. I'm a clinical educator here at Ultimate Medical. I'm a physical therapist and an assistive technology practitioner. I'm presenting today with my coworker, Britta Schwartzoff, and I'm going to let Britta introduce herself and start us off. Thank you all for coming.
Thank you, Marianne. Like Marianne just introed, my name is Britta Schwartzoff, and I'm also a PT by background and part of the clinical education team here at Ultimate Medical with Marianne and with Kristen Czat. So I've been practicing PT for about 12 years and have experience working in a few different clinical settings and areas within the industry. Now, as a clinician that has specialized in CRT or complex rehab technology, I have definitely witnessed the confusion and the complexity of the funding world firsthand. So I'm excited to spend the next hour together taking a little peek behind that curtain of funding in regards to standing technology. We do anticipate that you may have some patient-specific or state-specific questions as we go through today. So we probably aren't going to have time to dig into those specific questions during the hour, but we would love to connect with you and problem solve outside of the webinar. So Kristen's going to drop a link in the chat, and we also have a QR code at the end. So whatever way it works to access this via the technology that you're joining us from, this is a form that has a few questions that you can complete. And then if you say yes, that we can contact you, we'll reach out and we can do some problem solving together regarding your specific funding question. So when we're looking at the topic of this course, we were inspired from our own experiences as clinicians and talking with many clinicians around the country. There's not a lot of foundational information for therapists out there on how that approval process works for standing devices. So we wanted to pull a few pieces from this complex topic to talk through today. We're also feeling a little bittersweet today because this is Marianne's last webinar with us today before her upcoming retirement, and she has so much expertise in this area and throughout her career. So we are very grateful that she has graciously agreed to dig into this funding topic with us and share some of that amazing knowledge that she has. So with that, our learning objectives for the hour are going to be to summarize the process for how standing technology is classified through the Healthcare Common Procedure coding system. We're going to look at some of the differences between public and private insurance and explain how standing technology is reimbursed under each of these. And then we're going to look at that lovely medical necessity terminology. So summarize medical necessity and how it applies to standing technology. Now let's get started. Our short hour together is really going to be a 30,000-foot view of this process. Funding is complex, it can be challenging, and really it requires days of courses. So we hope to zoom into some of these topics and kind of that outer ring in future webinars. So stay tuned for more courses coming with this overarching funding theme. For today, we're going to focus on that middle grouping and look into some of the basics around these areas and then provide you with some resources. So if you want to dig into this more, you'll have some of these resources via QR codes. And then if that doesn't work for you the way that you're accessing, you can use a handout later on to access those as well. So for those of you joining us today that are new to the world of complex rehab technology, we wanted to take just a brief minute to introduce some of the different team members that are involved in the process and kind of their role throughout, because there are a lot of different moving pieces and moving people here. So this is a simplified version. Many times there are more people involved, but we wanted to give at least a few examples of these individuals. So we'll start with the most important person involved in the process, the individual we are all here for, so the user. In the clinical setting, we typically use the terminology patient. In other areas of the industry, you may hear user or end user or customer. So we're all talking about the same individual here, the one that is kept at the center throughout the process. They're active participants in the goal setting and the decision-making process. Then if we look at the medical practitioner, typically going to be our physician, our MD or NP. They're the medical expert. So they are going to be providing the order for the clinical assessment of the standing technology, and then they're required by the payer to sign concurrence, date concurrence with the recommendations that are made. Then we have the therapist, so typically a PT or an OT, and they are the clinical expert. So they're the ones completing the evaluation, determining the clinical presentation findings, creating goals with the individual, completing trials, and then providing those detailed recommendations and justifications for the equipment. So this could be an outpatient therapist, a school therapist. Sometimes it's kind of a teamwork between them as well during this process. And if we keep on going down, we have our assistive technology professional and our supplier. So you might also hear terminology of vendor. They act as the equipment expert. They process the paperwork. They submit the documentation to the payer, including things like HCPCS codes that we're going to talk about, modifiers, and more. And then they deliver and they maintain that equipment. The manufacturers are the ones that develop and manufacture the equipment themselves. In this case, the standing technology. So they are the ones that are going to submit for getting that equipment coded, which we're going to discuss. And then finally, we have the funding source or the insurance payer, which we're going to focus a lot on today. Each team member plays a really critical role in successfully securing equipment for the individual. So with that, we are going to start with our end goal, what we are all here working towards, which is getting that standing equipment approved and connected to the individual so that they can obtain the health and the functional benefits from the technology. From this end goal, we are going to work our way backwards to understand the process and to understand where the clinician or the therapist plays a really vital role during these steps. So we're going to go actually back past this point before the documentation was compiled by the supplier and sent to the payer for review with the many codes and those modifiers in place. And as we continue in reverse, we're going to make our first stop along this process at the point of the assessment and the trials of the standing equipment. So the therapist has met with the individual. They've assessed for the safety and the benefits of standing. They've undergone the necessary clinic trials, home trials, and this in itself is a very, very important part of the process. We're not focusing on this step during this hour, but we have other courses that are available that really dig into this, and we're going to have more courses in the future as well. So the therapist will get to the point where they need to provide the justification for the standing device or the LMN or the letter of medical necessity. So typically that therapist is maybe given an order form from the supplier or a quote or a price list or other document that's going to outline which pieces the team has determined to be necessary and that need that justification. So many times the therapist will see a bunch of codes associated with these documents and lines in the documents, and the codes will differ depending on the type of equipment that you are looking at. And this can feel a little bit overwhelming for a therapist, especially if you're a therapist that is newer to kind of the world of assistive equipment and technology. So what do all of these codes mean? Some of you may be familiar with more commonly used codes kind of in our CRT conversational language, like a K5 or a K0005, which corresponds to an ultra lightweight manual wheelchair. What might not be as familiar is that there are also unique codes that relate to standing technology. So what are these codes? These are what are called HCPCS codes, or Healthcare Common Procedure Coding System. So the HCPCS is a standardized set of codes that's used for billing items and services to all payers. So that includes Medicare and Medicaid. The HCPCS is divided into kind of two main systems or subsystems here. So we have level 1 codes and level 2 codes. Again, if you're newer to this side of the equipment world, you might think that you aren't familiar with these codes. However, if you are a practicing therapist, level 1 codes are actually CPT codes, and they're maintained by the American Medical Association. Standing technology and other what we call DME POS, which is durable medical equipment, prosthetics, orthotics, and services, so non-physician services, fall under the level 2 codes. So level 2 HCPC codes are what we call alphanumeric codes. So they're initiated with one letter and then they have 4 numbers. And that can be helpful when you're maybe looking at an order form and there's part numbers or model numbers. The HCPC code is going to be the one that's going to start with a letter, then it's going to have 4 numbers. So one question is that how does this equipment end up being connected to a HCPC code? So in order to connect, in this case, standing technology with a HCPC code, there are a few relationships between entities that are important to understand at a very basic level. So first we have CMS, or Center for Medicare and Medicaid Services. They overarchingly kind of maintain the level 2 HCPC codes. This system began back in the 80s, and in 2003, the Department of Health and Human Services delegated the responsibility to CMS to establish and maintain different items, including details regarding kind of this HCPC world. Palmetto GBA is contracted by CMS to assist suppliers and manufacturers in the proper use of the HCPC through what we call PDAC, or Pricing Data Analysis and Coding. PDAC is then responsible for maintaining and updating what we call the DMECS, or the Durable Medical Equipment Coding System, which is an online database for HCPC coding. So when we look at the coding process itself, there are multiple steps required during the process, and there are going to be differences present if the manufacturer is seeking a code verification versus if they're submitting for a new or a unique code. So for today, we're going to look at just a very simplified version of this process for code verification. So we're going to say that there is already a HCPC code that matches the details of the technology that the manufacturer has developed, but they are looking to get the equipment connected or verified to this existing code. Kind of on a small side note, depending on the classification of the device, the manufacturer may or may not need to do an official clearance or listing with the FDA prior to this application. So the coding verification is the process that allows manufacturers to request a coding decision on that DME POS item. So it's a responsibility of PDAC to review the submissions and then determine the appropriate HCPC code. So the manufacturer submits an application for code verification. PDAC reviews this, and then hopefully all things are as they need to be, all the documents are in place, and they provide their approval decision. And then once approved, the product is then listed within the DMECS pages. So let's explore that for a minute. The DMECS is available to the public and has a really cool interactive tool that can be helpful to use if maybe you're given a HCPC code and you don't know what that HCPC code means. So I think about back when I was a new clinician in seating clinic, and I did not have all the different seating cushion codes memorized. So I might get an order form for a seat cushion. I'd be like, oh, is this cushion coded as a skin protection or a positioning cushion or a combo cushion? And so I could take that HCPC code and put it right in here, and then it would pop out information on what type of description is included with that code. So it's the same here with standing technology. I can put in a HCPC code example here. I put in EO637, and it's going to tell me, oh, that's a combination sit to stand system. There's another way you can go about looking at this kind of within the DMECS pages. So you can also go to the product classification tab and look up equipment by either the manufacturer or by the HCPC code. If you look it up by the HCPC code, what's cool is that it'll give you all the products that have been code verified for that specific code. So example here, I just put in Ultimate Medical so you can kind of see some examples of what this looks like. If this is something you like to dig into, this is your jam, and you want to learn more about it, if you start digging in, you might notice that not all the manufacturers get their standing devices code verified, as these products are not on the official list of items that require code verification review. So in that case, the supplier will submit under the code that best matches that product. Here is a chart that includes different standing technology HCPC codes and their descriptions. So as an example, you can see the Zing MPS standing frame, which is coded as an EO641 on the left-hand side. That's a multi-position stander. And then you can see the Evolve on the right-hand side is an EO637 or a sit-to-stand stander. Included in this chart are the HCPCs also for things like integrated standing technology, so manual and power. You can see each have different descriptions and they have different clinical applications depending on individuals' presentation, their needs, their goals, etc. So we go into that in detail in other courses. So the equipment is now connected to a HCPCS code, and this HCPCS code is going to be the same across all payers. However, just because a product has a HCPCS code doesn't mean that it's going to get covered by the insurances, or the individual specific insurance or payer. So what happens is the payer then connects kind of these two areas by having their own coverage criteria guidelines that are based on the specific HCPCS codes. Or they may state it's a non-covered item, again, based on that HCPCS code. So in regards to Medicare, this includes information that they have located within their LCDs or their local coverage determinations or policy articles. Just as there are different clinical reasons for recommending different types of standing technology, there's also unique criteria for the different HCPCS standing codes. So with that, Marianne is going to get into kind of the payer world, the insurance world, looking at some of the coverage basics, the differences, the details within them. And so as we are swapping screens, we're going to get to know you a little bit better, those of you in the audience that can respond. So we're going to put some polls up on the screen and answer those if you're able to, and then we'll swap to Marianne.
All right, we'll give you a couple minutes to finish up your survey. I hope everybody will please participate. All right. Let's move on to funding. Now we know where the HCPCS codes come from, and we are starting to learn the language that the payers are using and how they process things. We're going to go through it. Again, this is a very high level view. So basically, we have two types of payers. We have public payers, which are Medicare and Medicaid programs, and we have private payers, which are independent insurance companies that are contracted. So we've got Medicare Part Cs. Within that, we have HMOs, MCOs, and ACOs. We're going to get into all this. Medicaid, and they also have the private insurance, MCOs, ACOs, MCOs. And then we have the totally private insurances, the Blue Cross Blue Shields, the Aetnas, the Cignas, the United Healthcares, etc. These are operating independent of the Medicare and Medicaid systems. So when we look, we're going to talk mostly about Medicare and Medicaid. When we look at Medicare and Medicaid, both of these systems have other plans, sub-plans, which are MCOs, HMOs, fee-for-service, and ACOs. So let's find out what they are. So with the Medicare system, so Medicare is the insurance that people get free of charge at 65. And what that covers is your hospital insurance, your doctor's bills, your x-rays, lab tests, things like that. That's Part A, and that's free. Then there's Part B, which is called supplemental insurance, which is what we pay for everything outside of that, for your DME, for your other services that aren't covered as hospital and medical benefits. And then we have Part C. Part C is what we know as the Advantage programs. We know that Medicare does not cover under Part B because Part A is only hospital insurance. Part B is where you would cover your durable medical equipment. They do not cover standing devices. Part C, which is the Advantage programs, which are the private insurance companies, some of them do cover it. So let's go into these a little bit different, a little bit more depth. So with the Medicare Part C, in 1997, the Balanced Budget Act enabled Medicare to contract with independent private companies to set up the Medicare Part C programs. They have HMOs, MCOs, ACOs, and fees for services. Part of the contract states that they must cover all of the Medicare Parts A and B services. So if Medicare has something that's an approved and it's a covered service, these MCOs and ACOs have to pay for it. But they also provide additional services. So things that aren't traditionally seen as Medicare and Medicaid. And if you looked at the Medicare, if you look at the Medicare coverage, it's going to say it's a non-covered service. But the Medicaid Advantage programs, or the Part C, can choose to cover those. And I think this is really important, especially talking about standing devices, because some of them do pay for it, but it's individual. With Medicare Part C, the copays and deductibles vary by plan, and it's what the individual chooses to do. You do not have to get a Part C. You don't have to get Part A. But if you choose to, you look at the plans, and it's a lengthy process, as somebody who's just gone through it, to figure out which one fits your needs. Now let's talk about Medicaid. Medicaid is insurance for low-income families. The funding is split between the federal government and the states, and the percentages vary from state to state. But each individual state establishes their own program and they administer it within the state. They must have all of the federally mandated benefits of Medicaid. The federally mandated benefits of Medicaid are your hospital. It's like your Part A of Medicare. The federally mandated for Medicaid are those same hospital services, labs, acute care, some chronic care. But then they also can contract the same with individual insurance companies to have an HMO, an MCO, or an ACO under the Medicaid umbrella. So both Medicare and Medicaid can have private companies providing the services to the user. So we're going to go through them all. We're going to start with HMOs. Health maintenance organizations are private insurance companies. They have a defined network of providers. So you can't choose to go to whoever you want to. You can choose, but it's within their list of providers. It may not be the person or the organization you want to deal with, but you can only deal with them because they are an in-network provider. Some of them do have higher costs if you do out-of-network. Where we start with an HMO is the PCP, the primary care physician. This is the person who has to order and refer all your services. You do not get coverage unless there's a referral from your PCP. How Medicaid pays the private and company to administer this is it's a capitated fee. What it is there is a set fee per patient per month. So if the capitation is set at $1,000, for every person they have enrolled in that program, they get $1,000 a month from Medicaid, from the state. From that pot of money, and it's not individual, it's not like a health savings account where this is my money and it's just for me. It's not. It's a pot of money that goes in to do the administrative costs, all the costs of running the HMO, but it also has to cover all the benefits and all the services. So you're going to cover all of the Medicaid benefits that are deemed by the state. You're going to cover, if it's a Medicare program, you have to cover the Medicare A and B programs, but you can have some additional services. I know it's like alphabet soup here. Managed care organizations, again, private insurance companies. When we're in Medicaid, and this is important because when we first came out with managed care organizations, the private insurers were using their criteria and their coverage to determine the coverage for the Medicaid recipient. That's not allowed. They have to cover everything that the state Medicaid covers. So if in your state, the Medicaid program covers and standing devices are a covered service or a covered item, that MCO has to provide it. Well, they have to cover it. We'll get into approvals later. So ACOs are accountable care organizations. They're groups of healthcare providers that coordinate care for a defined population. Here in Massachusetts, we have Mass General Brigham, which is the Mass General Brigham Hospital System's ACO for their patients listed. Some of them do have contracts with DME suppliers and other service providers, but a lot of them, what they do is they pair up with an MCO. Remember, it's a managed care organization who has a defined network of providers. They will partner with them and have them do that side of it, where the ACO just does the health and the hospital stuff. Again, it's a capitated fee for services, and they have to, if they're a Medicaid ACO, they have to cover all the Medicaid benefits. If they're a Medicare ACO, they have to cover all the A and B Medicare benefits. Plus, at their discretion, they can add additional services. Now, fee for service. Fee for service for both Medicare and Medicaid is what we're used to. It's the traditional way that an insurance company provides services. They pay the provider directly. So when you go for your doctor's visit, the doctors bill Medicaid or Medicare for that service. Medicare or Medicaid pays them directly for that service. So it's a fee for service, just what it says. Each bill is done individually and the money comes out of the greater fund. It's not like the capitated programs that you would have with the MCOs and the ACOs, because this is being done through the state or the federal government in the case of Medicare. All right, if your head's not spinning from all the insurances and the different types, which is why it's important to know what your patient recipient has for insurance, because it all changes. But now I think the biggest question that we all have, and especially the user, is it going to be covered? Is my insurance going to pay for this? You've heard of all the different types of insurances. Well, they all have different rules. They have to follow some of the same, but they all have individuals. So one way to be totally sure, or to find out the most information to see whether you have a chance at getting this standard approved, is to have the recipient call the insurance company. You can call, but they don't have to give you the information. If the recipient or the user calls them and asks specifically, do you cover HCPCS code EO637, sit to stand standards? They will say yes or no. Especially with the Medicare Advantage programs, this is so important. I've had many people who we assumed because they had Medicare, they couldn't get a standard. We had them call, and a lot of times I would sit with them while they called. We'd be on speakerphone, they give permission, and all that they have to do. And they say, do you cover EO 637? And they say yes. The next question is to ask for a copy of the coverage criteria. Some places, some insurances call them coverage criteria, some call them clinical guidelines. If you can get that copy, you have a really good understanding of what they're looking for and whether it's going to get approved. The other way to do it is to ask the suppliers, because the supplier or ATP can access them somewhat. With certain insurance companies, it's harder, but they may have it. The most time consuming, the least effective is an internet search. You put in Blue Cross Blue Shield, Florida, Northwood, whatever, DME fee schedule, coverage criteria, or DME provider manual. It takes a very long time, and it's not always 100% accurate because you can only get into what you can get into. So now we're trying to figure that out. But what do they do with that? They use medical necessity. Medical necessity is a term that every single insurance company uses, but the exact language is different from each state, each criteria, each insurance program, and within the insurance program, within the different plans. But even though there are variances everywhere, there are some central themes that happen. To get a list of each of the state Medicaid's medical necessities, you can use this QR code and it'll bring you to a website that lists the individual specifics for each state. It's an interesting read. It's not quick, but it's interesting. So when we talk about medically necessary, we talk about medical necessity all the time, that it has to be medically necessary. This is what I think one of the most comprehensive definitions of medical necessity. It's actually the state of Massachusetts. A service is medically necessary if it is reasonably calculated to prevent, diagnose, correct, cure, alleviate, or prevent the worsening of conditions that endanger life, cause suffering or pain, result in illness or injury, threaten to cause or aggravate a handicap, or cause a physical deformity or malfunction. And there is no other equally effective, although more conservative or less costly, course of treatment available or suitable for the beneficiary requesting the service. So basically, quickly, it's saying it's medically necessary if it's going to treat their injury or their handicap, prevent the progression of it. But there's not a more conservative approach or less costly. Less costly, we hear a lot about, because Medicare does not guarantee you, or Medicaid does not guarantee you the best equipment. It guarantees you the less costly alternative that will meet your needs. So when we're talking about documenting medical necessity, we'll talk about this a little bit more. We need to demonstrate why the specific piece of equipment you want is the only one that's going to meet their needs, and the less costly isn't. And it's adequate. You're not going up and above, you're getting adequate. You have to remember that it's only adequate. The other thing about medical necessity is that just because a PCP, a physician, a physical therapist, whoever says that it's medically necessary, doesn't mean it is. How many times do we work with people who say, but my doctor ordered it. I need it. It's got to get paid for. I need it. My doctor ordered it. That does not dictate medical necessity. You have to meet the criteria. So let's take a little bit deeper dive into medical necessity. So when we're talking about standing devices, they are medically necessary if they are based on an assessment of the individual and his or her medical condition. This is where the clinician comes in. You do an evaluation to determine their needs. It's considered effective for the patient's illness or injury or condition in accordance with generally accepted standards of medical practice, clinically appropriate in terms of type, frequency, extent, site, and duration. It's not experimental or investigational, requires adequate empirically based objective clinical scientific evidence on its safety and effectiveness for the particular use in question. So we're saying that you've done the evaluation and you've recommended something. What you've recommended has to be generally accepted, so it can't be something that's new and unusual. It has to have evidence supporting it and showing that it is clinically effective. We've already talked about is not more or less costly, is not more costly than equally effective. So if somebody is going to get into standing, do they need this, or if they can just use something smaller that's just going to get them into standing? You need to describe, based on your evaluation, why they need the other. And this is one of the most important things. It's not primarily for the convenience of the client, caretaker, or provider. We are not providing things to make it easier for people, especially with caregivers. If you're documenting that it is easier for the caregiver, it's going to get out. If you document that, well, he preferred this one over that one. It really doesn't matter what they prefer. It's what will do the job for them. So the stars are all based on evidence. So let's talk a little bit about evidence. We have levels of evidence, starting at the top, which is the strongest evidence, down to the bottom. The evidence for standing technology tends to be on the lower end. We don't have thousands of people in randomized controlled trials. Number one, it's hard to get that many people. Number two, the groups aren't totally homogeneous, which is what you really would like for a randomized controlled trial. Most of our trials are smaller, therefore they move down to the case report, the retrospective, or controlled clinical trial. Retrospective and prospective cohort studies, we have a lot of them, especially in the pediatric population, and there's some in the adults, where they take a specific thing that they're looking for, and they go back through medical records to see if that intervention has made a difference. Or, again, they take a cohort, they decide on the intervention, and they follow the people to see how it does to the future. The last one is expert opinion, which is why part of what we were saying is generally accepted. Do the people in this part of medical care accept that this is a practice and an intervention that'll work? So where do you find the evidence for standing? You can go on everybody's websites. We all have lists of references. You can pull the reference list from the end of this webinar or any of the other courses we do at Ultimate. We have a list of the studies that we have. Fastest place to find the most current ones from peer-reviewed journal is the Clinician Task Force RESNA joint paper. It's their position paper on the application of supported standing devices, the current state of the literature. And this is a link it'll bring you. It's a free article, and it has all the references. It also does a review and an analysis to kind of give you some idea where you're going. Why is this important? Because at times you need to put this into your LMNs, and we'll talk about that. So the guidelines for medical necessity. So criteria, guidelines, same word. Every single payer has their own. They also, within the payer, depending on the plans, have their own. So just because it's a Blue Cross Blue Shield doesn't mean all Blue Cross Blue Shields are the same. Within those guidelines, for standing technology, each individual standard may have its own criteria based on the design and function. They establish these guidelines based on the research evidence and the scientific evidence. Currently in the US, we have 2 commercially available guidelines. And what these guidelines are corporations who've developed these guidelines through work with clinicians, through work with reading the evidence, and the payers contract with these companies to either use their guidelines, or in some cases, there are companies that contract with the payers to do their medical reviews. It's confusing, which is why you need to talk to your individual insurance. So the 2 available guidelines are the Milliman Care Guidelines, or MCG, you'll hear it called MCG, and Interqual Guidelines. And for each HCPCS code, they have specific things that they're looking for in order to approve or deny it. So when we look at the evidence, what does this mean with the guidelines? From MCG and Interqual, these are their cap statements or summary statements of their guidelines for standing technology. MCG says that the evidence is insufficient, conflicting, or poor and demonstrates an incomplete assessment of net benefit versus harm. So basically, they're saying there's not real literature here, and they're suggesting alternative treatments. When you're documenting in the absence of scientific evidence, if you can put in, I'm not saying it's going to work, but it's worth a try, the specific evidence for that person. And we'll talk about it a little bit more. So Interqual's evidence statement is that there's insufficient high quality evidence to determine benefit, but standard use is supported by professional societies and clinical consensus. So they're going down to the lowest level of evidence, which is expert consensus, expert opinion, and they're saying that there is some value to what these experts are saying, even though there's not high-level scientific evidence. When we go through the guidelines, there is some consistent clinical guidelines that go through all of them. And you can read through them all. It's really fun, but consistently you have to have a neurological condition. CP, MS, spinal cord, TBI. There has to be a diagnosis for their condition. They have to be non-ambulatory or losing the ability to ambulate. So for your young children, it's usually if they're not ambulating by 1 or 2, depending on the specific guidelines, it moves into, yes, we can approve it. They have to be unable to stand independently. But once they are standing, they can maintain it with the standard due to residual strength, hips, legs, and lower body. It's important to remember. So when you're doing your documentation, all these clinical guidelines require specific things to be in their documentation. You have to document that you have trained either the user or the caregiver in the use of the equipment. You have to document that either the user or the caregiver has demonstrated safe use of this particular equipment. You have to document the trials because they have to be able to tolerate the upright standing position. And this is where I would put in that you're documenting, we've had so many trials, and say you're looking at range of motion. When we started the trials, the range of motion was X. At the end of the trials, the range of motion was Z. You were demonstrating clinical effectiveness and benefit. So we're going against benefit and harm here. Benefit for that specific individual for that piece of equipment. You need to document a treatment plan and that it's being prescribed by a clinician who's qualified. You have to include the goals, just like any treatment plan you write. The goals, the frequency, how long is this person going to use it? Some individual plans say that it must be 30 minutes a day, a minimum of 3 days a week. Again, if you can get the guidelines, you'll know what you need to have in there. You have to have a frequency of reevaluation because they don't want it just to stay. And also, as a clinician, you want to reevaluate because hopefully you're making gains and need to make changes. Justification of the device and accessory based on trained health professionals' evaluation. When you are justifying, this is a big pet peeve. Didn't mention in the beginning, I used to be a reviewer for Mass Medicaid. And one of my biggest pet peeves was when people were justifying equipment or accessories and stated adjustable angle foot plates necessary to accommodate ankle range of motion. But in their evaluation, they said the ankle range of motion was within normal limits. Make sure it's based on the evaluation and it truly reflects what you said in the evaluation. And it's not for the convenience of the client, caretaker, or provider. You don't want to say because it's easier for them. You want to say it enables them to, not because if it's better or worse, but it enables them to, and it's not just for their convenience. So when we get to specific, again, every payer, every plan, every piece of standing technology has different criteria. But there are, again, some consistencies throughout. Under or over 21 years of age, it's very unfortunate, especially in the Medicaid system, a lot of individual states will not cover standing devices for someone over 21 at this time. Does not have complete paralysis of the hips and legs. This is very common. And when you're documenting, you may have to be creative about them, but they're able to stand using residual lower body extremity strength. You need to make sure that if they say does not have complete paralysis, you don't put they have a 0.5 lower extremity strength. It's a wording and do it. Limited range of motion. It is recognized by a lot of insurances to be an intervention for contractures, but you have to demonstrate that stretching hasn't worked, that Botox and stretching and splinting, that no other interventions have had success. And if you've done the trial and you can document success, you've got it there. Hip subluxation, dislocation, alternative treatments haven't worked. Alternative treatments like bracing, surgery is something different. And bowel and bladder, it's important, though there isn't a lot of clinical studies supporting this, but there's a lot of therapist expert opinion and end user experiences. So if you can document that with the standing program, suppositories aren't needed, they've had decreased UTIs, it helps to get it through. All right, so we've talked a little bit about documenting. I know this is a lot. My head's spinning out. I can't imagine what yours is. To do the most effective letter of medical necessity, you need to get those criteria. You need to see, number one, what they're looking for to approve it, but also you need to see what they're looking for to deny it. In some, especially for Medicaids in some states, you don't have to do an LMN per se. They have forms that you can fill out and it documents what they're looking for medical necessity. So get those specifics. So when you're doing your LMN, if you have to do it, use those guidelines. Use that guideline to write your letter so you include what it needs to include and don't include what you don't want to include. You want to use the language in the guide. So you never know who's reviewing these. A lot of times they're an RN. A lot of times they can be a therapist. Sometimes they're just a clerk who's going through to make sure you've checked those boxes. Actually, Interqual's form is check boxes. And it said you check ABC, and it says the only way to proceed is if you have A and B checked. If you have C checked, it's denied. So you need to go through that and make sure you've got it on. You want to have any data points. If they're talking about residual lower extremity strength, you need to state in those words, they have adequate residual lower extremity strength. You want to document the results of the trial. You also want to use those guidelines, because if they say that they have to tolerate 30 minutes and you've only documented they tolerate 20, it's going to get denied. Add any specific improvements, benefits for that patient you can, because that can not take the place, but there is an absence of scientific evidence. So if you can provide patient-specific evidence, you're moving more towards that way that shows that it is effective in the benefit versus harm. We are going to have more courses on this. Told you it's a high-level view. LMNs could be a week. So you put it in and it's approved. Yay, it's approved. Wow. But there's a problem. The standard cannot be provided. The supplier's cost for the standard is less than the payer's reimbursement. Each individual payer determines the amount they will reimburse the supplier based on the HCPCS code. Some of them have a set fee, and the set fee doesn't cover the cost of a standard or that standard. It may cover a more basic one per HCPCS code, and the fees are different between a sit to stand, a multi-position, and a linear single position standard. A lot of other payers do what's called manual pricing. And this is done based either on the manufacturer's suggested retail price. And some states in Medicaid they will reimburse a percentage of that. I can't think of them right now. Sometimes it's 80%. It changes with every state. Other states do what's called AAC. So AAC is the acquired acquisition cost to the supplier. So the price that the supplier pays to buy that from the manufacturer. And what they will do is mark it up above that. But on that price, acquired acquisition costs includes any discounts that they get. It does not include shipping costs. It does not include the administrative costs to process it, the personnel costs to deliver it and build it. So it is just a percentage of what they actually paid for that piece of equipment. So it can be really frustrating because you've done all this work, it's gotten approved, but the supplier can't provide it. As a clinician, you're like, well, come on, you can lose money on this. No, they can't. We have to stay in business. We don't want to lose our providers, because then where are we going to get the equipment? Won't go on that tangent. So the other scenario is you put in the insurance claim and it's denied. It's time to appeal. Anecdotally, I'm hearing from people across the country, and I've seen some studies that over 50% of denials are either overturned on appeal, which means the appeal process, it's been approved, or they never make it to the appeal. They're overturned before the appeal happens. So let's talk about appeals. So appeals are federal and state laws based on the person's constitutional right to due process. Every payer within the plans, every type of payer, private, public, Medicare, Medicaid, HMO, they all have to have an appeals process. It's usually called appeals and grievance process. They have to provide what the process is to the individual so that they know their rights. If your prior authorization or your claim for a standing device or anything you put into the insurance company is denied, by law, the payer has to notify the user of the denial within 10 days of the decision making. Included in that denial has to be the information on the appeals process for that specific plan of that specific insurance. You have to request your appeal or submit your documentation for appeal within an established timeline. I've seen some as small as 5 days. I've seen 60, 30 days. But when the person gets the notification of the denial, it will tell you the days that they have, and they have to be the one to do the appeal, to request an appeal. It can be done by phone, by fax. Some do email, snail mail. Some even you can do it on their websites. So in that denial letter, they're going to get the information on how to do an appeal. Everyone should appeal. Don't take their first response as the end all be all. Everyone should go to an appeal. So there are 3 types of appeals. First is an internal appeal, which a lot of people call reconsideration, where you submit additional documentation to the payer for them to review and see and reconsider their decision, just what it says. These are people inside the insurer, inside the payer, who work for the payer, who are reviewing the documents. If you get a denial on reconsideration, you ask for an external appeal, which is an independent body, independent reviewers who have no connection to the payer, the supplier, or the manufacturer. A lot of times here in Massachusetts, they're lawyers who work for the Division of Appeals. It can be anybody independent that doesn't belong. Then you can present your case to them. When they read it, if they overturn it, fabulous. You can present information. A lot of times you will have a live hearing. If you are presenting as a clinician, tell them who you are, tell them your experience, tell them your qualifications. If you have certifications, you want to ensure that you are telling them that you know what you're talking about. If that gets denied, you have what's called a judicial appeal, which involves filing in the courts. And I'm just going to do it very general because there are specific guidelines for each state. What you want to do is you get in front of a judge. It's some states you're not allowed to add any additional information. What they do is they take the transcript from the external appeal and they send it. There's multiple levels for judicial appeals all the way up to the Supreme Court. So basically, don't give up. If you truly believe, keep fighting and go through the levels of appeals. There's about 5 levels total. So to understand your appeals process, for the different states, this is a website that's comprised of all the individual appeals processes for all the Medicaids within the United States. So you can look up your specific state and find the details out. There's contact information. To try to do this today, we'd be here all week. So if you're preparing for an appeal, again, I can't tell you how important it is to read the denial notice. You need to read it and understand it. Multiple times I get people that say it was denied and they bring me the denial notice and I look at it and I said, no, no, no. part of it was denied, but part of it was approved. They can do it by line item. So read it and also understand why it was denied. If it was denied because there's a lot less costly alternative, then your documentation for the reconsideration has to show why that less costly alternative is not going to meet their needs. If it's denied as far as medical efficacy, so the evidence they say it isn't effective, you're going to put in information showing that it is effective for this one person. You're going to include every specific you can. And if there's been a time period, there's usually a time period from the last trial to when you get to the appeal. You're going to reevaluate that person, officially or not, but you're going to look. And you're going to put into that appeal, since they have not been using a standard, they have decreased in range of motion, increase in suppository use, whatever the justification you have, because what you're doing there is you're showing benefit versus harm, but in reverse. You're showing the harm of them not having the standard compared to the benefits of. Again, include your qualifications. Let them know that you are qualified to be doing this. We'll have more. And basically just don't give up. There's plenty, there are alternative fundings and methods in every state, every community. And we're going to talk about that in another webinar. So we're going to go on a funding spree. And now I'm going to turn it back over to Britta.
All right, Marianne, if you want to go to the next slide, there was one more that you were gonna mention, but I'm happy to as well if you'd like. So this is another resource. Yep, this is another resource that is available to you. That's a wonderful tool that you can go to. It's evidence-based response to insurance denials of standing devices. CTF and NCART put this together. So this has some great information if you're navigating that appeal process to check out as well. Yes. Okay, so that is a lot of information to digest in 1 hour. We totally understand that. It's a lot for us to digest as well. So depending upon the state you live in, the payer that you're working with, you may be able to go right to an approval pretty smoothly, be able to get this equipment for the individual without major headaches. Or you might need to exercise some of your advocacy skills and push back against some of these denials with the appeals that Marianne just outlined so beautifully. So like she said, we don't give up just because we received a denial. There are pieces that then we can do from that point to continue to advocate for the individuals to receive the technology that is most appropriate for them. And that's what we want, is at the end of the day to get that end goal of connecting the right technology with the right individual at the right time to maximize their health and function. So like I mentioned at the beginning, we would love to connect with you on this topic. So in addition to the form that you'll be receiving from Ultimate regarding the course information, we would love to hear questions you have. If you've been having experiences and you're willing to give us some feedback on what you've been experiencing, we would love that as well. This is that same form that we linked in the chat. So depending on the technology that you're joining us through, you can do the QR code, you can click on the link. And then within that form, there is an option that if you are willing for us to connect with you on it, then it requests your contact information. So we would love for you to fill this out, and then we'll reach out to you to connect and problem solve together. So with that, that wraps up the webinar today. We do want to make a note that in addition to the other resources we had throughout the webinar, we also have funding guides within our Ultimate Medical web pages. So there's an Easy Stand funding guide that's available, a Zing funding guide as well, and then the 3 of our education contacts information here. So we want to thank you so much. We know it's a lot to dig into the funding piece, but it's such an essential component of what we do in order to get this equipment to the individuals that need it. So thank you for joining today, and we look forward to connecting with you all again soon.
All right, everyone, if you have any questions, go ahead and put those either in the chat or the Q&A function. And our education team will do their best to answer those for you. Just want to thank you all for your attendance in today's webinar. And I want to thank Marianne for this last webinar. Marianne's been here with me since we started education together, so definitely a bittersweet moment, but we wish her all the best as she moves on to retirement. Getting your CEU for this course, you should to receive your CEU credit, you must complete the survey at the end of this course, and that should automatically populate in your web browser when you click when you click leave webinar, excuse me. If that doesn't populate, don't worry, that link will come to you in a follow-up email you'll receive from Zoom in approximately 24 hours. You'll also receive an email from Ultimate Medical. If you complete that survey right away and you get 2 emails from Zoom and Ultimate Medical, you don't need to complete that survey again. Just one time is perfect. But if you have any questions, please don't hesitate to reach out to either our educators or our education team directly at education@ultimatemedical.com. Again, thank you for your time and attendance this morning for our webinar. We hope you enjoyed it, and we hope to see you again soon. If you have any questions after the conclusion, again, please email us at education@ultimatemedical.com, excuse me, and be sure to check out our on-demand education now available at learn.ultimatemedical.com. And I think maybe we've got a few questions.
Kristen, can you
Yep.
see them?
Yeah,
I
I
can.
think in the
The
Q&A
on-
we have those covered.
Yep.
So nothing that
on-
is for the group.
Yep. If you would like this presentation on demand, it will be going into the on-demand library on Ultimate's website. So if you're interested in going back and listening to something again, you will be able to access that in the upcoming days once it's placed there. All right. Any other questions? Well, thank you all for attending, and thank you so much, Britta and Marianne.
Thanks, everyone.
Thank you.